uncomfortable feelings, I think we can see as being signals to us that something in our life is wrong and something needs to be changed. And when you tell someone that what they have is a medical condition, you take the meaning out of it. We are diagnosing and treating depression in people who are in really bad circumstances, for example, in an abusive marriage. There's a little bit of evidence, in fact, that antidepressants might increase suicidal thoughts and suicide attempts in young people. The emotional blunting is sort of disinhibiting because people don't care about anything anymore. They think, I might as well just walk in front of the traffic.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being. How many of us now in the UK take antidepressants? Do we have reliable figures on that?
So I think it's about 8.7 million people in England. The data is collated separately for England, Scotland and Wales. So, about 8.7 million people, which is around between about 15 and 17% of the adult population.
Wow, and that's what's reported. Do you think it might be underreported?
I'm not sure how those data are collected, but in this country, our data on prescriptions and healthcare is pretty good. So I wouldn't think it's substantially underreported.
Yes. You have written that, and I quote you, depression has acted as a template for the creeping medicalisation of a widening array of life problems. So we established the fact that depression is not a medical condition. How should we conceptualize it then? What is depression?
So I think our old understanding that depression is an emotional state, which is a reaction to negative things happening in our lives, it is the way that we should understand it. That makes it clear that it's related to us. It is part of what we are as a person. It's part of ourself. It's going to be because our moods are affected by what we like, what we care about, what we value in life. And if things that we like and care about are going well, then we will feel good. If they're not going well, then we will feel sad or anxious or demoralized. So I think that's how we need to understand. We need to understand it as a meaningful emotional state, a meaningful feeling state, if you like.
Yeah, response to life circumstances, whether it's trauma, loss, grief, whatever. Right?
I mean, that's what emotions generally are. They are a reflection of our sensitivity to our environment.
Yes.
They are a response to what goes, what we like and what goes well for us and what's going badly.
Is that why you said depression is a reflection of our values?
Yes, absolutely. So
that's quite
how we feel about our circumstances depends on what we like, what we don't like, what we value, what we have come to believe is important. And that, I think, shows you how our emotions are deeply interconnected with our personality, with how we have developed, what we've learned and been taught to care about and to not care about.
Yes. One of the key ideas in your book, Chemically Imbalanced, is that by medicalising depression, we have done a disservice to people. You write that over-medicalisation, and I quote you again, gives people false hope and leads to over-prescription of potentially harmful drugs that, at best, offer ways to stifle uncomfortable feelings. There is something here that tells me that you believe that uncomfortable feelings are an essential part of life or the human experience. Is that correct?
Yes, of course. And uncomfortable feelings, I think we can see as being signals to us that something in our life is wrong and something needs to be changed. And as I said earlier, people aren't necessarily immediately aware of what that is. I mean, you might be in a terrible situation with, being bullied at work or in a difficult relationship, and it's clear what's bringing you down. But it might be more subtle than that, and you might not be immediately aware. And our feelings are a signal to us that something's not right in our life, and we need to have a look round and try and find out what that is and make some changes. And just to go back to that quote as well, the problem starts because when you medicalise something, when you tell someone that what they have is a medical condition, you take the meaning out of it, because most of us understand a medical condition as being like having, lung cancer or pneumonia or something like that. it's a biological process over which we have very limited control, and which plays itself out according to a set and predictable process. And that encourages people not to look for the meaning of their feelings. It encourages people to see them as if they were a medical disease, as if they were a biological state, and to rely on external treatments such as antidepressants or other sorts of physical procedures, rather than, as I say, trying to understand what those feelings mean, what they're signalling.
Yes, because if I'm led to believe that a pill could relieve my distress, I would put all my hope in that and perhaps not pursue other ways of help. Could this deflect attention from real problems in my life?
Absolutely. And, I think that sometimes we are diagnosing and treating depression in people who are in really bad circumstances, for example, in an abusive marriage. And by doing that, we are actually perpetuating that situation, because we're enabling people to think, oh, it's not my marriage, it's my brain chemistry, and I need to take this pill, and that's the problem.
I would think the antidepressants are keeping me going, but maybe the real issue, like an abusive marriage or soul-crushing job, that doesn't get addressed. Is there a line, I'm going to drill down a little bit, is there a line that we can draw between emotional pain or suffering that's part of the human experience and suffering that requires medical intervention? Or are you telling me, because some viewers might think, oh, it was a terrible time in my life, I couldn't function, I couldn't get out of bed, couldn't look after my children, some people are in a very bad shape. Are you telling me that all emotional turmoil is simply part of life and I have to deal with it some way, as harsh as it might sound?
So there are obviously differences in the intensity of people's feelings. So some people can get into a very severely depressed state, whereas other people never get depressed at all. There's a whole range of intensity of emotions that human beings experience. The problem is that we, even for very severe cases of depression, we have no evidence that those are triggered or caused by a biological process. And we also do not have good evidence that biological interventions like antidepressants or other biological interventions are actually effective. Certainly not that they're effective in the long term. You've probably heard of ECT, Electroconvulsive Therapy, which is given to people with severe depression.
Yeah, would you please in brief explain this to our audience?
Yes, so electroconvulsive therapy is quite an old treatment that was introduced in the 1940s and 50s. And it was actually introduced for people with schizophrenia initially, but then then drugs for schizophrenia came in, and it became sort of redundant really in that area. But it persisted for the treatment of people with severe depression.
What does it do?
It consists basically of putting an electric current through the brain using 2 electrodes either side of the brain, to give people an electric shock, which induces an epileptic fit. So people have an epileptic fit. For that reason, people are given an anaesthetic and a muscle relaxant, so they're not aware of having the fit and so that they don't cause themselves any damage. Now, it does seem that ECT can occasionally, temporarily, literally jolt people out of a depressive state. I think that's because you're giving someone a mild brain injury when you're giving them an ECT, and part of the effects of that are that people lose their memory. And
wow.
And sometimes also people get into a slightly sort of disinhibited, fatuous state, almost becoming a little bit sort of manic, and that basically is superimposed onto their underlying feelings of depression. So temporarily, people's mood is lifted, but the evidence is that they sink back into the same mood state after a few weeks.
Yeah, I think that's what my mom used to have. She had, I'm almost certain that these sessions she had, we call them electricity sessions in Arabic back in Egypt. I don't think they helped a lot. They just made her very, very, very tired.
Yeah.
And she didn't continue with that treatment. Yeah, another nuance, please. What if depression is associated with suicidal thoughts or something like self-starvation. How do we treat it?
So again, the problem is that there's no evidence that antidepressants reduce suicide or that ECT reduces suicide. There's a little bit of evidence, in fact, that antidepressants might increase suicidal thoughts and suicide attempts in young people from randomized controlled trials. And so even if depression is associated with suicidal thoughts, that doesn't necessarily mean that taking a medical approach is going to be helpful. Now, I'm not saying that we shouldn't look after people who are severely depressed and or suicidal. Clearly, we need to, if people are really severely depressed and, can't get themselves out of bed, can't feed themselves, we need to look after them. We need to care for them. Almost everyone in that situation will get better eventually. So I don't think we need to go filling them full of antidepressants or other drugs or shocking people's brains. We need to look after people. We need to have patience. We need to keep them safe. We need to gently encourage them back into life again.
Hi, I'm Hala, your host today. If you're enjoying what you see, please hit that lovely subscribe button. It will mean a lot to us. Or maybe a small podcast now, but with your support, we can build this channel together, one step at a time. Thank you so much for being part of it.
Yes, you just mentioned that using antidepressants might increase suicide rates. Did I understand this right? I mean, what is the mechanism here around this paradoxical effect that a drug that is supposed to relieve the stress might eventually intensify it?
Yeah, so that's a really good question. And again, we've no idea what the brain mechanism of this is, but it seems to be that in young people in particular, some antidepressants anyway, can make them feel quite agitated. And as part of the agitation, some people get sort of ruminations, start ruminating, and sometimes they can have suicidal ruminations, and sometimes that can lead to people harming themselves. And randomized controlled trials that have compared people with depression taking a placebo and taking an antidepressant have shown that in young people, there is a slight increase in suicidal thoughts and self-harming behaviour in those taking antidepressants compared to those taking a placebo. Because, of course, lots of people will be started on an antidepressant because they're feeling suicidal or because they're harming themselves. So it is quite difficult to disentangle what's happening. But there is this evidence from these randomized trials that suggests that the drugs can sometimes induce or worsen these effects. Yeah. And we really don't know how that, the mechanism, the biological mechanisms that drive those effects. And we don't know how that relates to the other effects of the drugs, the lethargy and the emotional blunting. Some people describe how the emotional blunting is sort of disinhibiting because people don't care about anything anymore. They think, I might as well just walk in front of the traffic. So it sort of disinhibits their suicidal, that disinhibits the restraint that they may have been using to stop their suicidal impulses.
Yeah. I have a very interesting quote from the NHS. The NHS website says SSRIs will usually be the first type prescribed, like the first type of antidepressants, because the side effects are generally easier to manage and they are less likely, this is a funny sentence, I can't say it in a straight face, and they are less likely to cause serious problems if you take too much of the medicine. I've never read that before. Even if you take too much, it's going to be fine.
Right. So I'll explain why they're saying that. They're saying that because the older antidepressants, like the tricyclic antidepressants, which were developed in the 60s and which were the most commonly used antidepressants up until the late 1980s when the SSRIs came in, are highly sedating and highly toxic drugs. So you don't need to take too many extra pills to get a serious heart condition and die.
I see.
Whereas the SSRIs and these tricyclic drugs were strongly sedating, so they would knock people out. If you took a full dose that's prescribed for depression, you'd find that it was really quite difficult to get up in the morning the next day. People generally developed some tolerance to that effect, i.e. the effect wore off because there were changes in the brain that combated it. but nevertheless, these drugs had, very noticeable what we might call side effects or effects. The SSRIs have much more subtle effects. Some people might not even really notice that they're taking a drug. Some people find it's only when they reflect back on how they were after they've stopped taking the medication that they realise how it was affecting them, because it was really quite subtle.
Some medicines have side effects as long as an arm. When I started estrogen, progesterone, the leaflet of estrogen is huge, totally scary. Some doctors might say it's a medicine. All medicines have side effects. Professor Moncrieff, you're a medical doctor. Are you making the case against antidepressants specifically, or other medications as well?
I think the considerations that I think people have got to bring to bear on decisions about taking antidepressants apply to all medicines, okay? And it is true, all medicines have side effects. So you as an individual, if you're deciding whether to take a medicine or not, you need to weigh up whether the likelihood of these side effects and what they would consist of is going to outweigh the benefits that you might get from this drug. So this is why it's really important to stress that the benefits of antidepressants are very small and possibly nil compared to taking a placebo. So, the considerations on the plus side are pretty slim. On the negative side, it is true in some ways that modern antidepressants have fewer strong side effects, strong immediate side effects compared to older antidepressants, but they do nevertheless have some common adverse effects that I think have not been widely enough publicised. One of these is dependence. They induce physical dependence. So when people try and stop them, particularly if they've been on them for a long period of time, they will get withdrawal symptoms. And those withdrawal symptoms, although they include physical symptoms like dizziness, and some people get these electric feelings in their head, like a sort of an electric shock. So you get those physical symptoms.
Spontaneously?
Yes, yeah. Very unpleasant, as I understand, as you can imagine. So there are these physical symptoms of withdrawal, but withdrawal can also produces emotional symptoms, particularly anxiety and panic and fear.
After I come off antidepressants?
Yes. Because if these drugs are suppressing your emotions and then you stop them, you get a sort of rebound effect that your emotions can bounce back even more intensely than they were before you took them. So people often describe when they're coming off antidepressants, they feel intense anxiety and they're very tearful. They're emotionally, up and down.
Everything's coming up the surface.
And emotionally sensitive, exactly.
I've come across the works of Professor David Healy, a long-standing critic of antidepressants, particularly the link to increased suicide risk. In one of his expert reports, he wrote, SSRIs can make an individual who may not have been likely to commit suicide before the onset of drug therapy, more likely to commit suicide now. Now, we touched on this. Will I find this side effect in the leaflet of my antidepressant and other side effects?
So I think you will now, but I'm not certain. But they certainly added the warning in America, and usually what they do in America we do too. How many people are actually alerted to this effect is another matter, because who sits and reads all the small print in your leaflet?
I would trust what the doctor is telling me, and I wouldn't read it.
As I say, I think this effect seems to be most likely in younger people. So I think it's quite a rare effect in general, but it does show up in the trials in younger people. Probably does also happen in older people, but again, I think that's even rarer, so very rare. Nevertheless, of course, suicide or suicidal behaviour is a really major concern. So of course people need to be warned about it.
Yes. I come from a Muslim background, and the Quran says we have created man in hardship. Like the origin of creation itself is hardship. We were made in and for constant toil. It's not a brilliant idea. It's not the most pleasant one, but this seems to be the case. I mean, apart from childhood, hopefully, but once you start a family, that's real life.
And that it is through getting over hurdles and difficulties and challenges that we develop and that we flourish, isn't it? It's what enables our skills and our abilities to be honed, to come to the fore.
And from an evolutionary perspective, when we were hunters and gatherers, our brains sustained so much more. Stress was, I always say that stress was going hungry for days, or running from predators, or suffering 3-4 stillbirths in a row. This gives me hope that my brain can help me in difficult times, that I can overcome failing marriages, grief, a terrible job, that I can do this. But if the medical community is telling me, no, it's something in your brain, have this pill, this magic, beautiful pill, and you're going to be fine, that's a difficult job. We're asking patients for too much to be their own doctors. It's not fair.
I mean, of course, human history is, shows us how difficult human life has been for centuries. I think it was Hobbes who said human life is nasty, brutish, and short, or something like that.
Life is not fair, Steve Peters.
Yeah. And we're very lucky to be born into the time and place that we are, and to have a much better, much easier lives, relatively speaking, than our forefathers. That's not necessarily true in all parts of the world, of course, with all the conflicts that are going on. And so, of course, people have always looked for a magic pill. People, there's always been this dream that you could take a pill and all your troubles would go away and you'd be happy forever. And, people have written literature about this, Aldous Huxley's Brave New World. So it is understandable that people are still attracted by this idea that there is a pill that will make you feel better and make your problems go away. But we know from history that there is no such thing.
And we prescribe pills for them to deal with problems that are maybe social or existential in nature.
In the past, probably most of the time, what people were given would be inactive and harmless. Nowadays, we are giving people real chemicals that really, change the activity, change the normal chemistry of your brain. That's going to have harmful consequences of one sort or another. Even if they're just minor harmful consequences. So handing out magic pills is a really serious thing nowadays. If you're handing out real chemicals for unrealistic hopes.
One of my favorite movies of all times is One Flew Over the Cuckoo's Nest. Have you seen it?
Yes, yeah.
It's a mad movie. I love it. It raises profound questions about human autonomy and power. Who gets to decide what's normal and what needs to be fixed? In your view, does psychiatry, at least in the UK here, balances well this dynamic relationship between authority and my rights, my autonomy?
So I do, absolutely, I think that happens. So psychiatrists haven't asked enough questions themselves. And so they are passing on a very partial view of human nature and human suffering to their patients. But they're not necessarily, that doesn't necessarily mean they're holding back things that they know that they could pass on. As we were saying earlier, I think many psychiatrists just assume that depression must have some sort of biological component, and they've not really asked themselves or thought deeply about whether we might be able to think about depression differently. They've not really questioned what the drugs that they're handing out are actually doing. So I think misinformation is out there, is passed on to patients, but it's not necessarily given deliberately, because I think the people passing on the misinformation have been misinformed themselves.
Do difficult life events, the loss of a loved ones, again, failed marriage, trauma, severe stress, inequality, does that change my brain if I experience them negatively, I mean?
So everything that happens to us has an impact on our brain and biology, and there's also some evidence that trauma changes the brain in various ways, probably makes your stress response more sensitive.
Okay.
It affects your whole body, not just your brain. So yes, negative life events affect our biology and affect our brains.
But there's nothing to fix it.
But no, we don't fully understand how.
No.
And of course, and as I say, that's, everything that we do affects our brains. And affects our biology. It's not just major traumatic effects. I'm sure that, having good experiences affects our biology and our brains too.
Yeah, true. I think I shared with you off air that I took antihistamines for a period of time, 2 months or 3 months. And even the innocent looking antihistamine affected my brain negatively. I couldn't walk in a straight line. And antihistamines, they're everywhere. And I remember when I text one of my friends telling her about that, because she has severe allergy, she used to take them. She told me that I give them to my child. She's 9 years old. Whoa. And I'm pretty sure I had some sort of dependency on them, because without them, my sleep was even worse. But I use AI, basically, Gemini. Gemini is brilliant in helping me manage the negative brain symptoms of the antihistamine, and they recommended approaching my GP, take lesser dose for a number of weeks, then coming off completely, and I managed eventually. But it felt like a huge weight on my brain. My balance was totally off. There was a huge fog on me, and that's just antihistamine. So I can just imagine the terrible side effects of something like SSRIs. You have coined the terms disease-centered model versus drug-centered model in relation to how psychiatric drugs work. This is central to your philosophy. Could you please explain to us in very simple details the difference between them? Talk to me like I'm a child. So.
Yeah, I'll try. And I think this is a really important point. And it reflects on the previous point that we were making, this, because psychiatrists are so signed up to this disease-centered model of drug action, they're passing that on to patients, and they're, I think, for that reason, not appreciating the real nature of the drugs they're prescribing. So this disease-centered model is the standard medical idea that drugs like antidepressants or antipsychotics or drugs that we prescribe for people with bipolar disorder work by targeting some underlying abnormal mechanism that is leading to the symptoms of the condition. It's a model that is borrowed from general medicine, where most drugs do work in that way. Now, it's not just that this model is not just saying that the drugs should be targeting should be curing the condition, should be targeting the ultimate cause of the condition, because something like the Ventolin in your asthma inhaler, the drug that's in your asthma inhaler, I would say it works in this way too. It's not treating the causes of asthma. What the Ventolin does is it relaxes your airways, which have become constricted that's what causes the wheeze, that your airways have tightened up. And the Ventolin relaxes the airways, so the wheeze goes and you can breathe normally again. So it's not combating the cause of the asthma, but it is targeting the mechanisms that produce the symptoms, that produce the wheezing.
This is a drug.
So this is the disease-centered model. Okay. Now, so that is how drugs like antidepressants are assumed to work. It is assumed that there is some underlying biological mechanism, like the constriction of the airways in asthma, and that the antidepressant reverses that and thereby improves the symptoms of depression. But there's another explanation for what drugs like antidepressants might be doing for drugs that are prescribed for mental health problems. And this is the idea that they are having psychoactive effects, that and we've sort of led up to this by what we've been talking about before. This is the idea that these drugs change the normal state of the brain. They change your normal brain chemistry. They put it into a different state compared to how it would be if you hadn't taken the drug. And they do that in anyone, not just someone who has a condition, but in anyone who takes the drugs. So anyone who takes, for example, let's take an obvious example, a dose of Valium, a tranquilizer called Valium, will feel substantially different. They'll feel calm. They might feel a bit sleepy, depending on how much they've taken. They might stagger a bit if they've taken a lot, because Valium has quite similar effects to alcohol. They might feel a bit less inhibited and a bit more social at lower doses. So those effects are not arising because Valium is treating some underlying chemical imbalance. They are arising because of the effects of the drug on the normal state of the brain. And anyone would experience those like anyone experiences the effects of alcohol, although, of course, there is individual variation. So what I am saying is that drugs that are prescribed for mental health problems need to be understood like that. We need to understand how they change our normal mental states and feelings and behaviours in the same way that we would understand Valium, alcohol, cannabis, etc. Okay? Now, we've already talked about how drugs like antidepressants come from lots of different chemical classes and produce different sorts of alterations. So the older antidepressants, particularly the tricyclic antidepressants, have sedating effects, make people feel quite sleepy and drowsy, and, as I said, are prescribed for insomnia, in fact. And they are quite different from the effects of the SSRI antidepressants, the more recent, the more modern antidepressants, which don't have profound and immediate sedative effects, although they do often make people feel a bit lethargic. But they do have this emotional numbing effect, which is probably connected with the sexual numbing effect that they've been shown to have. Then there are drugs called SNRIs, selective serotonin and noradrenaline reuptake inhibitors. So they're meant to work through by increasing the activity of serotonin and noradrenaline, which is another brain chemical that's been proposed to have a role in the onset of in causing depression, although the evidence on noradrenaline is no more convincing than the evidence on serotonin. These drugs make people feel really quite groggy and foggy.
Yes.
Although, again, they're not classical sedatives. They don't just send people to sleep. So the important point is different antidepressants have different sorts of effects, and obviously these effects will interact with how someone is feeling. So if you take something that really sedates you and sort of wipes you out, you probably won't be quite as in touch with your feelings as you were without it, because you'll actually be just overwhelmed with fatigue and sleepiness. If you take something that numbs your emotions, then of course your feelings of sadness or distress won't be so intense. So this is what I'm calling a drug-centered model. It's the idea that the effects of the drug on the normal brain produce mental and behavioural effects that interact with our underlying feelings and difficulties, and may make them feel easier to manage, or may just obscure them temporarily, replace them with feeling drugged. We can understand this effect again if we go back to the effect of alcohol. If you're feeling really down or really stressed about something and you go out and have a ton to drink, your worries go away temporarily, your sadness temporarily goes away because you're under the influence of the alcohol. I'm not saying that psychiatric drugs like antidepressants are exactly the same as alcohol. Clearly they're not. They have different sorts of effects. But the principle is that they change our normal mental state and behaviour, and those changes are superimposed onto what people are feeling underneath. Another example that I think is useful to give is the example of opiate anaesthetics like morphine, for example. So these drugs have some directly target pain mechanisms, but they are also what we might call psychoactive drugs, mind-altering drugs. They put people into a different sort of mental state, an altered mental state. And one of the characteristics of this altered mental state that is induced by opioids or opiates is feelings of emotional indifference. So people who've taken opiates for pain will often say that they still have some pain, but they don't care about it anymore. And that aspect of their effects is what I would call a drug-centered effect. It's an effect that is induced by the mental alterations that the drug produces rather than a targeted action on a particular causal mechanism.
So in relation to depression, sorry if I'm overly simplifying this in a very naive way, the disease-centered model is like, okay, I have this is a very bad analogy, so bear up with me. I have, my bike has a broken part, a broken wheel. The mechanic fixes the wheel. The bike is fixed and working again. And this is what some psychiatrists are relying on in justifying giving antidepressants. You have low serotonin in the brain. That's an automatic change or fault in your brain. Antidepressant fixes that. You're cured, and you obviously challenge this idea. Whereas the drug-centered model is like you mentioned alcohol, or you're sad and exhausted, you have some wine, you feel better, but that doesn't mean that you had wine deficiency.
You haven't fixed the bike. No, that's right.
No,
Yes.
you haven't fixed anything.
Yes.
And in relation to depression, this might sound like a doctor saying this medication, this antidepressant will change your brain function. It has some side effects. It might make you feel detached or sleepy. It might bring some relief, but you're not cured. This is the drug-centered model, and you advocate viewing antidepressants in this framework of drug-centered.
Exactly. I advocate viewing all of the drugs that we give for mental health problems in this model, because we know that these drugs have effects on the brain and affect our mental states as a consequence of that. That's not in dispute. And we have not identified underlying causal mechanisms that they might be targeting. So obviously, viewing their effects in this way, it seems to me just has to be our default way of understanding the nature of drugs like antidepressants. But also, this applies to the use of stimulants which are prescribed for ADHD. It applies to all the drugs that are prescribed for bipolar disorder and drugs that are prescribed for psychosis or schizophrenia.